Welcome to our webinar series for professionals.
Welcome everyone to this follow-up webinar from where we left last time with the Trucheck webinar, the cancer screening test for the 75 odd solid cancer types. So today we're going to dive deeper into the different cancer tracking and diagnostic tests that we offer. So we move from screening to detecting and treating. So it's like a nice flow and journey that we're going to experience today. I'm Anne-Catherine, co-founder of Nordic Laboratories and DNA Life, a group of companies dedicated to change healthcare through functional medicine and personalized medicine. So remember all that the tests that we are going to talk about today, you can get in your VMS profile. And of course, we will send the recording to you once we have it uploaded and added into mailing to you. So we will share that, and Stefan will also share his slides, so you can get those and follow those when you have time for that as well and look deeper into it. The next one, the webinar we have will be on August the 25th, which is striving through stress on genetics of resilience. So, you know, like dopamine, oxytocin, adrenaline, serotonin, all those things that, impacts on how we feel, how we are, how we act. So I'm very much looking forward to that. But that's next time. So today, the star of the show is Stefan Schuster. So he's a specialist in circulating tumor cells and holds a PhD in medicinal chemistry. And he's published different articles about the value of liquid biopsies. So Stefan and I go on for a few years where we've been looking at different tests that could be relevant to present, and it took us a long time, and Stefan went around different places as well until he finally has found his place in this with detecting and treating and screening and monitoring cancer. So if enough of my talk, I'm going to pass on the stage to Stefan. So so you can learn from his knowledge bank. And of course, as always, I will take down the questions if you have those and write those in the chat. Then I will take Q and Q. I will take the Qs and Stefan will do the A's at the end. So Stefan, you are allowed to share your screen and say hello. I will mute myself.
Yeah, hello everybody. Thanks, Anne, for having me here again, now for the second time from February. It has been quite a while, but I guess it's quite consequent to talk after we have been talking back in February about screening, that we get now to the next step to detecting cancer in symptomatic patients, and then afterwards to give you some insights on how we track and monitor cancer, and afterwards also some insights which might be of interest for you, how to treat cancer. To treat cancer, we will keep it a little bit short because it's a huge topic, and maybe we can talk on another time about this to dive deeper into this topic. So everybody who does not know us so far, I want to give you a very short introduction about Datar Cancer Genetics. I joined Datar Cancer Genetics 1st of January 2019, so I'm now with the company for 3.5 years. I've been in the field of liquid biopsy for 10 years now, and in the field of assay development and diagnostic development now for more than 14 years. Our company, Datar Cancer Genetics, is based in India, UK, and Germany. So we have labs in UK, in Guildford, in India, in a small town called Nasik with just 3 or 4 million inhabitants. Nobody knows this town, but it's yeah, very nice town there. Our labs are ISO 15189 accredited, CLIA accredited, CAP accredited. We have in the UK also UCAS accreditation. All the tests that I will present today to you have also a CE mark. And currently we have worldwide employees, more than 250. So far from our side. Now let's go into the topic directly. First of all, maybe a short comparison between tissue biopsy and liquid biopsy. So the challenges with a tissue biopsy are here written on the right-hand side. Actually, it is in some cases it's pretty difficult to access the tissue. For example, in the lung, liver, you can have a lot of side effects. When you think about gliomas, it's very difficult to retrieve the tissue. And then if you have a tumor with multiple sites, with multiple metastases, the tumor heterogeneity is an issue. Maybe also the intratumoral tumor heterogeneity is an issue. And also how to monitor this from a longitudinal point of view, because assessing or doing a tissue biopsy more frequently is not very common. And of course, patient ease and comfort you have when you perform tissue biopsy. Always, or not always, but in most of the cases, you have some side effects. You have to go to the clinic. Sometimes it takes a little longer. Sometimes you can be released from the clinic at the same day. Nevertheless, it's quite cumbersome when you look at the tissue biopsy. And the liquid biopsy tried to overcome all those challenges that you have to face with a tissue biopsy. Of course, just to be clear, tissue biopsy is still standard of care in the field of oncology. Nevertheless, we see more and more patients where you cannot perform the tissue biopsy or where it's difficult. And for those cases, for those niches, we want to present a solution for symptomatic patients. Because from a liquid biopsy, you have easy access. You see basically the whole tumor at a glance. So you see the whole heterogeneity in one prick of the blood. You can easily do this several times to monitor what's going on. And of course, for most of the patients to have a simple blood draw, it's much more convenient compared to a tissue biopsy. Just let me show you some insights on the tissue biopsy, because when you look at the literature concerning tissue biopsy for prostate, you see very, very different numbers. And sometimes you ask yourself, why are those numbers, especially when it comes to the side effects, so different? So they range from 1% of side effects up to 40% of side effects. So it looks like it depends largely on the operator, on the doctor who is doing this, but maybe also on the technique which is used. Nevertheless, one of the most difficult things is that you can still miss in 20 to 30% of the cases the tumor when you are using the transrectal ultrasound biopsy for cancer. Meanwhile, it's the technique has developed from 2019. Nevertheless, it's still a very difficult procedure, and you have quite a lot of side effects in the man. So what do we offer there in this case? This is what I want to present you today is different from what I presented the last time. The screening approach, which is called Trucheck, which is meant for asymptomatic patients with no cancer history so far. And now today I want to emphasize on one side on TruBlood. TruBlood is basically a blood-based, organ-specific, non-invasive diagnostic biopsy or minimal invasive diagnostic biopsy for symptomatic patients. Very important to note that TruBlood is always organ-specific. So let's say you have some patients with a high PSA value, or patients that have some suspicious findings in the imaging, in the lung or in the liver, then you can apply TruBlood kidney, TruBlood lung, TruBlood prostate, whatever. It's our organ-specific test. We had until now more than 57,000 patients so far for validation. So our database is meanwhile quite big. And we have an overall sensitivity of 89% to detect those cancers and our overall specificity of 97%. So what is now the principle behind it? Actually, the way how we detect, or the biomarker that we use in our approach, are the circulating tumor cells. Now, how do we distinguish, or how does our method distinguish from other methods? Actually, we also apply the whole blood. So we take simple EDTA blood. We do a blood cell, red blood cell lysis. And afterwards, what we do is called somehow functional enrichment. It's actually that we have developed a special media where we put all those white blood cells, this PBMC pellet, into it for 5 days. And because of several factors that are in there, growth factors, etc., all healthy, all normal cells will die. And those cells who remain are what we call circulating tumor cells. What we do afterwards is that we stain them, and because of the staining, we gain much more, much higher sensitivity, etc. So we are very, very, very sure about what we are doing there. And what we just published last week from our screening approach, because one of the questions very often that we get are those cells that we find really from the tumor. And as it's published now, I can deliberately say you, yes, they are from a living tumor. Why are they this? Because we were able to compare from early stage cancer patients prospectively. So we haven't known upfront that they had cancer. So they underwent mammogram, afterwards a biopsy, and we took the blood before the mammogram. And there we looked at certain mutations inside of those cells and compared them if they were also found in the tumor. And we found a concordance of more than 80% in those between the cells, the CTACS, circulating tumor cells, and the tissue. So we are very sure that what we find definitely comes from a living tumor. Just to give you an overview how many studies we've done so far. So we performed the TruBlood study with more than 15,000 patients. A study which has now a little bit more patients and will be published soon is about prostate cancer with more than 500 patients. We have a very special study. It's a kind of a niche thing. It's about central nervous system malignancies, so basically gliomas, etc. There we have meanwhile more than 500. At this date, we had 130, but we have meanwhile more than 500, and we will publish also a study together with the Imperial College in London soon. And then we have the Resolute trial with more than 14,000 asymptomatic individuals that were before mammography, pap smear, before other cancer screenings. So just to give you an overview what we have done so far. Already in 2000, this was published actually in 2020. So it consists basically from data from 2018, 19, and 2020. What we have done so far with subcohort of 30,000 patients that we already published is, on one side, are we able to detect circulating tumor cells in cancers? And on the other side, are we able to provide diagnostic relevant information about this type of cancer just by using the circulating tumor cells? So what have we done in this study? We compared the findings on the CTCs, where we characterized the cells, for example, for estrogen receptor, androgen receptor, etc., to the tissue. And we were able to retrieve diagnostic relevant information in more than 93% of the cases. So meanwhile, we got a little bit better, but those were the results 2 years back. So coming now back and then focusing a little bit more on TruBlood. For whom is TruBlood really recommended? On one side, it's recommended for symptomatic individuals who have been advised to have a tissue biopsy to check for malignancy. So what we can do from a simple blood draw is to distinguish if you have a benign or a malignant disease. As I said before, we don't want to go for the standard of care, but there are a lot of patients who fear the biopsy, and TruBlood can be used in those cases as kind of a triaging tool. So we are working meanwhile with a big clinic in Spain, for example. We are working with big clinics in UK, in the US, and India, in this field, where you have patients, where you have, for example, an unclear MRI, unclear imaging, high PSA values, you see something in the lung, and because lung biopsies are always kind of difficult, you can use TruBlood as a triaging tool to determine, okay, which patient has the higher risk to have really cancer. Then it's meant also for patients, as I just said, where the invasive biopsy has been inconclusive, or you had other inconsistent clinical observation. And it's quite interesting for me now, as we have this test now for 1 year on the market, to see how often we get in the report as a diagnosis, unclear MRI or unclear whatever, and then afterwards TruBlood is being performed, or where we use it as a kind of a niche product, but it's just for you to let you know. It's meant also for patients where you observe a new tumor and you want to know if it's a new tumor or if it's a metastasis. We had, meanwhile, quite a lot of cases, for example, breast cancer patients who developed new lung metastasis. And the question was, is this a new lung cancer or is this a metastasis? And we are able to distinguish between those cases, because it has also clinical implications afterwards, how to treat those. So why should you apply TruBlood? Yeah, totally non-invasive. It's a marketing term. Now I know that especially in Germany, we have some partners who would say doing a blood test is definitely not non-invasive, it's minimal invasive. So you have basically no pain, you have no stitches, no scars. It's only a blood draw. And the risk is very, very, very low to have any side effects because of a blood draw. And you have also no risk of injuring any other organ or bleeding, especially when you think about biopsies that are done in the lung, liver, pancreas, or of course also in the brain. So we can provide real-time data and cover all active sites. So just to give you an example, which we had just 3-4 weeks ago, we had a patient that came to us because of high PSA value. and he had repeatedly very high numbers of CTCs. Interestingly, not specific for prostate. Nevertheless, because this was the first goal, they did the biopsy, they didn't find anything. But afterwards, what they are now performing is to have a full body scan to see where those circulating tumor cells come from. I can update you and everybody who's interested as soon as we have the results from this MRI. But this is how it sometimes also goes, that you will discover something else which it was not suspected or which was not expected, basically, in the patient. And of course, TruBlood can be performed as often as necessary. Hopefully, this is not the case for most of the patients. And it's even viable, so it can be even used when the primary or metastasis are not detectable. For example, we have sometimes the case, so it's not validated, especially for the CAP syndrome, cancer of unknown primary. But if you say, okay, I want to know if this cancer really comes from the pancreas or if it comes from the ovaries because it has some neuroendocrine functions, but we only saw the metastasis and the primary is unclear. So what we can do is at least to test if it comes really from the ovaries or from the pancreas, for example. This is what we can do basically with TruBlood. So what are the main characteristics of TruBlood? We can determine if the tumor which is there is malignant or non-malignant with a specificity and sensitivity of more than 90%. We can confirm the organ of origin, but of course, it's like with a true biopsy, the treating doctor has to tell us at which organ we have to look at. This is very, very important. Otherwise, it does not work because we are applying a lot of different antibodies to determine also the subtype and where it comes from, etc. So this is something you have to tell us basically. We can classify the cancer type, if it's for example, an adenocarcinoma, if it's a squamous cell carcinoma. This is everything. This is basically what we can tell you. And if wanted, we can do also in addition a ctDNA analysis to tell you also already if you have some possible targets for antibodies, etc., or that you have also something, and then where we come to the next step, where you have something where you can start monitoring already because you have already the first value for it. This is a publication or article publication from 2019. So please note, we have meanwhile a lot of much more patients so far. Nevertheless, it gives you an overview of how many breast, how many head and neck cancer patients, lung cancer patients we had until 2019 when this study was published. And also what I want to tell you, when we started this, we were wondering, because we have different methods how to detect those circulating tumor cells and how to specify them. What we are basically detecting are the CTCs. So if cytokeratin positive, EpCAM positive, CD44 negative. But when we do apply only this, we find in approximately in a population which is aged between 40 and 70, in approximately 3.7% of all of a normal healthy population, we find those what we call circulating tumor associated cells. And what we did afterwards, because it was clear to us that if we detect it like this, then we will be in trouble. So what we did afterwards is to further specify those cells and using additional markers. organ-specific markers like Datar for breast cancer, like AMCAR for prostate, etc. And this rate now decreased, our positive rate, down to 0.7% approximately. And you may ask also, is this only doable for early stage cancer patients or late stage cancer patients? So what I can tell you so far is that what I've shown you, and meanwhile we have also some new numbers, so that we have also a sensitivity in early stage cancer patients above 88-89% so far. So in stage 1 and stage 2, we will also find those cells and can tell you from a diagnostic perspective if this is malignant, not malignant, and what subtype you would face. And what you can see down here, this is if we find in non-metastatic patients and metastatic patients those cells. This was back in 2019, as I said, very early numbers, and already back then it was basically equal. So let me give you some insights from our breast data. This one we have published already last year in February as a poster. So why do we think that also a test like TruBlood can be or the patients can benefit also in something like a breast cancer screening or breast cancer determination, and can be of an advantage for the patient in the end. So when you look at Germany in 2018, the data is very well published. Everybody can look this up. We had more than 130,000 mammographies with positive findings, but only 17,000 had cancer. So now what is done usually with those 130,000 patients afterwards, they get a second mammography, and out of those 130,000, 30,000 got a biopsy. And the question is if you can bring this number down, or minimize the numbers of patients who have to have basically a tissue biopsy. And this is where we see our niche for TruBlood in breast cancer. So just to let you know, there we published a clinical pre-validation with more than 550 patients. And we had also a prospective clinical validation with more than 960 patients. And just to keep it short, we compared our findings prospectively with the histopathological evaluation, which was done after we had done the blood draw, and which was done based on the tissue biopsy. And we had 91% sensitivity, 98% specificity, and 96% accuracy. So in basically 90% of all the cases, we have also found the cancer as in the as given in the tissue biopsy, and also could tell you if the diagnosis that we have given was comparable to the tissue result, basically. Lung data. Well, it's estimated that all 60%, that 60% of all lung biopsies are benign. And I just had recently in my family someone who had to undergo 2 lung biopsies, and I can tell you it's not really fun. So it's kind of a difficult procedure in certain cases. It depends always where you have to take the biopsy. Nevertheless, it's kind of a cumbersome procedure. And just to let you know, this was published already in 2020. We had 1,200 individuals in this clinical trial. And we were predictive of malignancy in 95% compared to the tissue analysis. And we had an overall concordance, so it was comparable from tissue and CTCs in 94.9% of those cases. And there you can find also something different. And what we did also there was that we compared if we can distinguish between metastasis in the lungs or new primaries in the lungs. And this is what we also published in this study, but I don't want to go into detail because it's getting then very complicated. And as I can imagine, most doctors don't have these cases usually. And now some insights about CNS data. When you look worldwide at the patients who receive a brain biopsy, approximately it's estimated that 1.5% of the patients will die during the brain biopsy. So it's quite urgent that we need there something which can at least give you a hint. Do I really have to do a biopsy in this patient or not upfront? And as I initially said, we have done or we are about to publish a clinical trial together with the Imperial College, where we also prospectively, before a tissue biopsy was done, got the blood. And we had there also more than 100 different cases. Those cases that you see here, those were patients from India. Now we are looking in the publication with the Imperial College purely on patients from Britain. And we were able to detect glial CTCs in 80% of the malignant CNS tumors. And they were absent in 89% of the so-called benign tumors and 100% of the other other types of cancers. So we are able actually also to discern, and this is what we showed also now. This is quite old, this study over here, what you can see. And 2 years later, we are able to have a sensitivity and a specificity which is very close to 95, 96%, because we have really worked on our procedures and know much better what we can do. For example, one very important factor that where we were not quite aware in 2018, 2019 was that the time of shipment is also very, very important. So all the shipments for TruBlood have to arrive within 48 hours in our lab, which is usually not any issue from Europe or from the East Coast of North America. So what are frequently asked questions for TruBlood? Can TruBlood differentiate between squamous and adenocarcinoma? Yes. Can we tell you the grade of the tumor? Of course we cannot, because for this you have to have a histopathologist looking at the tumor sample. Can we use it in hematological malignancies? Of course not. We are only focusing on solid tumors. And can you find CTCs in blood when there is a carcinoma in situ? Definitely yes. So what I can tell you, because TruBlood Prostate just received back in February from the FDA the breakthrough device designation, and we also had received this for breast cancer from the FDA back in November, and the FDA asked us for breast cancer also determine if we can find circulating tumor cells and determine them in stage 0 patients, so in so-called ductal carcinomas in situ. And what I can tell you, yes, we can definitely find them in stage 0 patients with a sensitivity of maybe 75 to 80%, because the FDA claims, and this is maybe different to the general hypothesis, that ductal carcinomas in situ can metastasize, especially in breast cancer patients. So how is the sample collection? We need simple whole blood, 20 ml for TruBlood. The patient has to have an empty stomach for 10 hours. The patients must not have undergone any chemo, PET-CT, MRT, any CT procedures 24 hours prior to sample draw, no transfusion in the past month. And of course, we need a complete TRF with signatures, and always also what you can bring down, that you give us some recent doctoral letters, some insights, what is going on in the patient, so that we really know where we have to look at to determine what if this is, to determine basically at which organ we have to look at. So assuming that we have found now our tumor, what can you do afterwards to perform monitoring? So what we apply is a method called CancerTrack. This is actually a method that's been on the market much longer than I've been with the company, since 2015, 2016. And it's basically a minimal invasive blood test that uses specific molecular biomarkers that are derived from cancer cells. On one side, to determine some therapeutic targets, drug resistance conferring mutations, newly acquired mutations, early detection of disease progression, and of course, recurrence monitoring. So this is our approach, how to detect or how to monitor cancer patients. It's very important. CancerTrack is only meant for those who were already diagnosed with a tumor. And it's not Trucheck, it's not TruBlood that you apply in already cancer patients. You apply, or we apply, for monitoring purposes, always CancerTrack in cancer patients. So we can detect, we are using basically circulating tumor DNA. I don't know if I have to go into details about circulating tumor DNA, but let me drop 2-3 sentences. Circulating tumor DNA is shed by tumor cells during when you have basically a tumor inside. They have a certain length, and this is how, for example, you can distinguish them from other genomic DNA. So you can simply, by the length of those parts, you can distinguish between tumor DNA and normal DNA. And there has been, meanwhile, a wealth of data out there about showing that detecting circulating tumor cells is definitely a good monitoring tool. So I think CancerTrack is the only test where we only have case reports, simply because of the fact we are applying a method that is used also by others. Nevertheless, what is interesting for us, that we can combine it also with circulating tumor cells. Maybe also one point on the circulating tumor cells in this setting as a monitoring tool. I think circulating tumor cells are very well suited as a monitoring tool alone in non-metastatic patients. But when it comes to metastatic patients, you face issues because either they have developed stem cell characteristics, or there's a hypothesis where you, especially when you have additional tumor growth, where you have a so-called homing effect, that the CTCs are going back into the tumor. So there are a lot of issues when you look at them in the metastatic situation, but in the non-metastatic situation, they're definitely well suited to be used as a monitoring. So we use, on one side, CancerTrack as a combination of a prognostic and a predictive marker. So we can tell you if certain antibody-based therapies would work or not. Then prognostic markers like P53, if you have there a mutation in this gene, which will give you a less favorable diagnosis, for example. this is what we can detect also in addition with CancerTrack. And of course, what we have seen so far also in our clinical trials, that when you start a therapy, that after week 9, between week 9 and 12, we see there is a kind of a window where you can detect if those CancerTrack markers like CTCs, like the ctDNA goes up or down. And when it goes up, then you are very, very likely to see a treatment failure afterwards, also in the imaging a few weeks, maybe a few months later. So this is where you can maybe afterwards try to align the therapy according to what you have seen. And of course, it's detectable usually at a small tumor size. But also what we have to say about the ctDNA, it's definitely not detectable in all of the patients. But generally said, if you don't detect it in a patient, it's actually a good sign. So this was not published by us, but it gives you kind of an idea if you have an advantage or disadvantage. It's kind of a small study, but I think it resembles very well what is known so far of ctDNA. So if you can detect the ctDNA, then you have a much less favorable outcome in the patients. And if you cannot detect the ctDNA, then you have a much, much better outcome. And this is what you can generally tell afterwards. And if you have a mutation tracking, you also see if you see something afterwards, then if you don't see anything, it's much, much better compared if you have seen any of those ctDNAs. So this is basically the disease-free survival or progression-free survival, what is shown here. And this is basically true for most of the patients. What we have done so far, just give me some case reports already back from January 2016. So here we had a stage 2 adenocarcinoma of the lung. A common EGFR mutation, which is very common in lung cancers, was detected in 2016. They started the gefitinib therapy, which is directed against this EGFR, and monitoring with PET-CT, and the liquid biopsy detected an emergence of a new mutation coming up. And especially in those cases, you can switch then the therapy, and they switched from gefitinib to osimertinib, and you've seen afterwards a decrease in this patient. So this is how you can deal, especially in those. Meanwhile, ESMO also just published last week, I guess, kind of a guideline for certain types of cancers where you can use circulating tumor cell as a tool to monitor cancer and to also to adapt the therapy according to the findings in certain types. This is a very, very typical case, lung cancer. Now, I want to show you also some things about combination of CTCs and ctDNA. So this patient was a breast cancer patient. You have seen that we have an increasing number of copies of this mutation, and we had an intermediate low to low number of CTCs in this patient, and you can see it was a metastatic patient. And we used it basically as a monitoring tool. And compared to what we have seen in imaging, also the number of CTCs of the copy number went down, and also the number of CTCs went down, and you were also able to see this at this stage in the PET-CT in this patient. So you can basically use it as a monitoring. Also over here, a combination of a prostate carcinoma patient where we were able to detect an IDH1 mutation. And we saw an early detection of the recurrence. So here, basically the patient had some bone metastases that were treated after directly at this stage, and where the numbers and also the CTC numbers and also the ctDNA, percentage of ctDNA found in the blood went basically down. So just to give you a short overview, we are using basically for CancerTrack a 52 gene panel. So we are looking at certain fusions over here. We have certain hotspot genes, more than 44. We have copy number genes where we look at copy number variations, fusions, NTRK1, NTRK3, red, ROS, BRAF, important in certain tumors, ALK fusions. This is what we basically detect in CancerTrack. And of course, we can combine it also with circulating tumor cells. I will give you also a comment on the numbers that we find now when we come to the next step, where it's only about treatment optimization for cancer patients. So it's basically the same, the sample collection as it was before for TruBlood, apart from that we are using a DCGL tube and a 10 ml EDTA vacuum. So this is the only difference. Basically everything else stays basically the same, only that this ctDNA is much more stable compared to when it comes to early detection or screening tests. So we get also shipments from Australia, from the West Coast of the US. So this is not an issue with this test. Chemoscale. This is where it begins now to get interesting, because it's always a question how to adapt the therapy. And we are using also for this approach Chemoscale or this circulating tumor cells, but in kind of a little bit different manner as what we are using it in TruBlood or in CancerTrack, for example. So why are predictive diagnostics important? Basically, all new cancer drugs have by default diagnostics given as a standard. But it's actually not mandatory for the old chemotherapeutic agents. And when you look at the literature, it depends a little bit, but usually you have lasting success only, and this is not my number, but this is what is given in the literature, between 2 to 20% of all chemotherapies. So in most of the cases, at a certain stage, the patient will relapse. The question is always when this will happen. And this is something no one can tell you for sure, but it looks like that cancer is, and I think everybody is aware of this, sometimes very, very hard to cure, especially when you have already the second progress or you are after the second chemotherapy or even after the third chemotherapy. It becomes more and more difficult. So what do we do afterwards? So we have a cancer patient, and there we are applying again our media on the white blood cell pellet. And after 5 days, all the normal cells went away, and what remains are those clusters. And what we are doing for each Chemoscale patient is actually kind of a small TruBlood test to be sure that those cells that we find really stem, for example, from the breast, from prostate, etc. But this is an internal test. We don't note on this. It's just for us internally to make sure that what we see really stems from the organ that was given to us, because you are surprised how many times we read prostate cancer and in the end it was colon cancer, simply because somebody got a phone call or whatever. And what we find there, those are the circulating tumor-associated cells. And this is where we test the different substances on those cells. Those are definitely not just the CTCs. Those are the cells that actually give those cancer cells an additional survival advantage compared to single circulating tumor cells, because those are very fast eradicated from the bloodstream. Here we have, among those cells, tumor-associated fibroblasts, tumor-associated macrophages, tumor-associated leukocytes. So they prevent basically anoikis, a special kind of apoptosis, if you like, for the circulating tumor cells. And afterwards, we stain them again, and we find usually many of those, and those are being tested afterwards with different concentrations of the respective chemotherapy. We have done already in 2020, we published this study, a study with more than 5,000 patients, where we compared the outcome of chemotherapy that was being applied with the outcome in the patient, basically. And we had several subgroups. One most interesting subgroup that I can tell you was that we compared living tissue and circulating tumor cells chemosensitivity in approximately 250 cases. And we found a concordance of more than 93%. So the cells that we find in the bloodstream react pretty similar to what we find also in the tissue. So this is a very important factor. So this tells us again, okay, the cells that we find really come from the tumor. And then what was also interesting, it's something we have to bear in mind a little bit. In pre-treated patients, we saw a concordance as a prognostic value in 87%. So if the chemotherapies did not work on the circulating tumor cells, in 87% afterwards, the therapy failed within 8, 9, 10, 11, 12 months. So this is very important to bear in mind, because the value when you look at therapy-naive patients is a little bit lower. It's only 60%. So the concordance in therapy-naive patients is only 60%. And we think this might have to do that you have, at the beginning of the first chemotherapy, different clones, and nobody knows for sure which clone will develop afterwards. And after the first chemotherapy, you have a certain subtype of clones, and those you can attack more in a more targeted way. Let's keep it like this. So there are certain hypotheses, but just to let you know, in pre-treated patients, we have a concordance of 87% concerning in vivo treatment failure. And when it comes to the positive case, it's also around 80 to 85%. So if it works at our end, at the circulating tumor cells, it will work in 80 to 85% of the cases also afterwards. And as said, we had already 5,000 patients here. What is tested? Usually we test up to 28 cytotoxic substances, or we test in generally speaking, in this assay, only cytotoxic substances. So we don't test any antibodies, any small molecules, or any hormone treatments, because we are looking at the death rate of the cells. So we're using basically the average fluorescence intensity. And this is what we use. And for this, we need to have cytotoxic substances. What we can test in addition is, for example, repurposed drugs such as metformin, aspirin, where it's clearly stated in the literature that you may also have a positive effect on cancer cells. And of course, we can also test biologicals like artesunate, curcumin, vitamin C, etc. Here we are quite flexible. Usually we have a panel of approximately 30 substances that we test in addition. Yeah. And after 9 to 12 weeks, you should apply, if you want to do it good, some kind, either another chemoscale test or a CancerTrack test to see how the tumor characteristics have changed. Because we had 3 years, a very interesting case. We had a patient, she received, she had already several types of chemotherapies, and what we have seen so far, that basically nothing worked in the patient. So everything was below 30–40%. So it was really difficult what to choose. But interestingly enough, in this case, a biological had a very high efficacy in the cells, on the cells. And we retested the patient 6–7 weeks afterwards. And interestingly enough, it looks like that the artesunate has killed a lot of the other subclones or sensitized the existing subclone, because now a lot of the normal chemotherapeutics were working again. And so it's kind of interesting to see. And unfortunately, we don't have any trials on that. But here you can see how an kind of considered alternative treatment can also bring a benefit to the normal guideline-based treatment. So they can really work hand in hand. The question is how to prepare a trial for this. This is not our duty, not our job. We just deliver the tools to detect this. And of course, with each progression and recurrence, you should retest what therapies are likely to work or not. I haven't shown you the report for the other tests because they're quite simple. It will basically tell you, yes, you have cancer, no, you don't have cancer, and you might have this subtype of cancer. This is what we tell you in TruBlood. In CancerTrack, we will tell you, did we find any mutation, and what was the minor allele frequency, and basically some kind of a mutational burden percentage. This is what we're going to tell you there, and the number of CTCs. And what we will tell you here, just to give you an overview for the normal cytotoxic drugs like vincristine, oxaliplatin, paclitaxel, etc. If they are working or not, we consider all those, because for this we have those data from the 5,000 patients. Everything which is above 50% is a good drug response, a high drug response. This is basically the cell death rate. Below 50% to 25%, it's an intermediate response. So if you have another drug that you can choose from above, this would be definitely an advantage. And those drugs who have an efficacy below 25% are considered as non-responding drugs, basically. And then we have certain panels, and here on a purpose for the alternative drugs, for the biologicals, we don't give you any kind of a signal, even between 55% or glutathione in this patient was 0%, simply because it might be that some of those substances also have a kind of an immune stimulating effect or another effect on the circulating tumor cells. And because the data, and we haven't done any clinical trials on those substances, and this is why we don't give you any signal, because there you as a therapist, as the treating physician, the treating doctor, has to choose wisely where you have some experience, where you don't have experience, etc. And this is why here you don't find any no response, intermediate response, or high response scale. Sample collection, as it's basically the same set as with TruBlood, also the same preconditions. The only thing what you should bear in mind, if you have a patient under treatment, usually we can perform this test also 24 hours after the chemotherapy has been given. But if you have certain drugs, not like 5-fluorouracil, which is washed out and have a half-life, a certain half-life rate of maybe several hours. But if you have a drug like docetaxel or paclitaxel that might have a half-life of certain days, then I would assume, or we would recommend to do the test only 3, 4, 5 days after our chemotherapy has been given. So coming now to my last slide, what is the take-home message? So early detection using blood is definitely possible. We have validated this for more than 60, 70 different solid tumors, but I think most common are at the moment, for sure, prostate, breast, lung. Those are the ones that we see most often, or in between always also some liver malignancies. Then monitoring, definitely the combination of CTC and ctDNA offers relevant benefits, because you get not only a tool for monitoring and looking for the relapse and recurrence monitoring, because also ctDNA gives you insights on if you have new arising resistance mutations, if you have mutations that can be targeted by other drugs, etc. So it's also a kind of a predictive tool. And Chemoscale, definitely personalized treatment, also with biologicals and chemotherapeutics. And to my knowledge so far, the clinical trial that we published there with more than 5,000 patients, there's nothing comparable out there to date. So we definitely can say that testing the chemosensitivity makes absolute sense. I didn't go into detail about our very comprehensive tests, which are called Exacta, because then it gets very, very complicated, and we are adding much more markers. So you can just imagine Exacta as a combination of ctDNA and CTCs, mRNA, pharmacogenetics, immunocytotherapy, etc. I don't want to talk about this. Here we kept it somehow simple, and just remember that there is something like Chemoscale where you can also personalize treatment just using the circulating tumor cells. So thank you very much, and I'm open for your questions.
Thank you, Stefan. As always, thank you for a great presentation. And of course, when it's completely automated, it takes away the risk of human errors.
Yeah. I would say we have automated it to 90%. Of course, there's always something you have to do by your hand, but what is the most important thing, the readout is automated.
What I have noticed is that you keep publishing, and you keep aiming also to get these FDA approvals, etc. So you are in this yes. constant quest of continuing being approved and like showing that your test is working in different areas.
It's definitely the case that the FDA looks over our shoulder every half year in person in our labs and sees what we and wants to know what we are basically doing. And now that we have also the FDA breakthrough device designations, shows us that what we are doing is highly clinically relevant, especially for early diagnostics. Later on, when it comes to therapy management, it's a little bit more complicated. Nevertheless, what we are doing is of clinical relevance and was approved by already very high authorities.
Mm-hmm. So then I think that was perhaps what was most relevant for this talk in regards to some of the questions that did come up. But I think it could be just to finish this could be interesting with this case that we had with this woman who had cancer and had a test done, and she's having treatment through the hospital, and the hospital was like offering like their standard treatment, but having done and that was the chemo. No, which one is it that does suggest treatments?
Yeah, that was the exacta. This was the exacta test. So when it comes to we are dealing, of course, worldwide with certain oncologists in the UK, in Germany, in India. We are directly working with oncologists, and there we offer this exacta test. And exacta is a very complex test, very comprehensive test. And it's a pity to see when somebody wants to do this test and pays for this test. And what we always say afterwards, you need to have someone to understand this test. This is very, very important, because otherwise, and I think in this case, the treatment was delayed by 2 or 3 months in the end. And there, especially in such cases, the characteristics of the tumor can change a lot. Did you mean this case, basically?
I don't know if I was at that point, but I just know the fact that their standard care was probably the worst choice from the test. So it was a question of like trying to get the oncologist to change. But what I also find interesting, and what many of the practitioners here probably also find interesting, is for sure the list of additional treatments that you can offer. Yeah. So like the vitamin C or the artemisia or antibiotic treatment that will then support the treatment and the whole knowledge around this. And one was asking me about like, does the doctors at all know anything? And yes, of course, we are still in this where we have to kind of educate some of the oncologists because they don't necessarily know this. But hopefully this fight will, as it is now, benefit the patients that are taking up the fight and doing this test and trying to educate their oncologists, and then working with all the surrounding information where you as a either as a nutritional therapist or as a medical doctor can add extra treatments so that the success of the treatment in general becomes better. So of course now it's a bit uphill, but going forward this will become more and more like mainstream knowledge, and it will be easier for us to push, I believe.
Yeah, I think everybody has to be aware that we are having more and more therapists that either try to combine both worlds in a kind of a intelligent way. And I think it makes definitely sense to combine those treatments in the end, because we see that the patients benefit from this in most of the cases. Also, when it comes afterwards to PET-CT or other tumor markers that are being tested, that they are going down simply because you just started a therapy with biologicals in addition to the chemotherapy, for example. It's definitely making sense, and the question is how to use them wisely, because most of the, for example, vitamin C, this is something you can use when you have every 2-3 weeks a normal chemotherapy. Vitamin C is eradicated very, very fast from the system. So if you do this 2 weeks, 1 week before another treatment starts, then the side effects or the combination effects are likely to be very, very low. And this is also true for other drugs. But in this case, you are definitely the specialist and you have to choose. And if you need somebody who gives you some advice, we can definitely tell you some practices where we've been working now together for several years, and we'll give you some certain advice on this.
So if you are sitting out there feeling a little bit, oh, this is new, I need to get some support for this, please reach out to us. Yeah, we can support you. Stefan is good to give his thoughts and yeah, to support you, because
not as a therapist, but definitely to give you some address or some point of contact where you can where you can ask, where you can exchange your thoughts, etc.
So please reach out if you sit with that patient where you thought we need to do some extra for this person. So thank you everyone for having stayed tuned for an hour and 15 minutes. And thank you, Stefan, for educating us and sharing all the knowledge that you can with us. I wish you all a great summer month, at least those of you who is in the northern area where we have summer. And I'll see you in August, hopefully, for the next webinar on resilience. And I will send out the recording and the slides as well for you. So if you don't know what to do, you can always revisit this presentation. Thank you, everyone. And thank you, Stefan, very much for your time.
You're welcome.
Bye.
If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.